Welcome to This Week in Surgery, your filtered medical journal summary. Looking to stay up to date with the latest medical research but short on time? This Week in Surgery has you covered. Our podcast provides you with a convenient, on-the-go solution to keep you informed about the most significant developments in the surgical field. Each episode offers a filtered and concentrated summary of key journal articles, allowing you to stay informed without the need to sift through pages of research papers. With This Week in Surgery, listening is faster than reading, and you can consume valuable medical knowledge while commuting, exercising, or during your daily routine, including in the operating room. This week in surgery, we will be discussing recently published articles. First, Annals of Surgery. Human Immunodeficiency Virus and Hepatitis C virus-related disparities in undergoing emergency general surgical procedures in the United States, 2016 to 2019. Objective: to determine whether people living with human immunodeficiency virus, PLIV, and people living with hepatitis C virus, PLWHCV, experience inequities in receipt of emergency general surgery, EGS, care. Background: PLIV and PLWHCV face discrimination in many domains. It is unknown whether this extends to the receipt of EGS care. Methods: using data from the 2016 to 2019 national inpatient sample, we examined 507,458 non-elective admissions of adults with indications for one of the 7 highest burden EGS procedures: partial colectomy, small bowel resection, cholecystectomy, operative management of peptic ulcer disease, lysis of peritoneal adhesions, appendectomy, or laparotomy. Using logistic regression, we evaluated the association between HIV/HCV status and the likelihood of undergoing one of these procedures, adjusting for demographic factors, comorbidities, and hospital characteristics. We also stratified analyses for the 7 procedures separately. Results: after adjustment for covariates, PLIV had lower odds of undergoing an indicated EGS procedure, adjusted odds ratio, AOR, 0.81, 95% C, 0.73 to 0.89, as did PLWHCV, AOR, 0.66, 95% C, 0.63 to 0.70. PLIV had reduced odds of undergoing cholecystectomy, AOR, 0.68, 95% C, 0.58 to 0.80. PLWHCV had lower odds of undergoing cholecystectomy, AOR, 0.57, 95% C, 0.53 to 0.62, or appendectomy, AOR, 0.76, 95% C, 0.59 to 0.98. Conclusions: PLIV and PLWHCV are less likely than otherwise similar patients to undergo EGS procedures. Further efforts are warranted to ensure equitable access to EGS care for PLIV and PLWHCV. Prognostic Relevance of Primary Tumor Sidedness in Early-Stage Colorectal Cancer, an Integrated Analysis of 4 Randomized Controlled Trials, CHCOG 2003a. Objective: the aim of this study was to determine the genuine prognostic relevance of primary tumor sidedness, PTS, in patients with early-stage colorectal cancer, CRC. Background: the prognostic relevance of PTS in early-stage CRC remains a topic of debate. Several large epidemiological studies investigated survival only and did not consider the risk of recurrence so far. Methods: patients with stage 2/3 adenocarcinoma of the colon and upper rectum from 4 randomized controlled trials were analyzed. Survival outcomes were compared according to the tumor location: right-sided, cecum to transverse colon, or left-sided, descending colon to upper rectum. Results: a total of 4,113 patients were divided into a right-sided group, N equals 1349, and a left-sided group, N equals 2764. Relapse-free survival after primary surgery was not associated with PTS in all patients in each stage. Hazard ratio, HR, adjusted equals 1.024, 95% C, 0.886 to 1.183, in all patients, 1.327, 0.852 to 2.067 in stage 2, and 0.990, 0.850 to 1.154 in stage 3. Also, overall survival after primary surgery was not associated with PTS in all patients and each stage, HR adjusted equals 0.879, 95% C, 0.726 to 1.064, in all patients, 1.517, 0.738 to 3.115, in stage 2, and 0.840, 0.689 to 1.024, in stage 3. In total, 795 patients, right-sided, N equals 257, left-sided, N equals 538, developed recurrence after primary surgery. PTS was significantly associated with overall survival after recurrence, HR adjusted equals 0.773, 95% C, 0.627 to 0.954. Conclusions. PTS had no impact on the risk of recurrence for stage 2/3 CRC. Treatment stratification based on PTS is unnecessary for early stage CRC. Impact of neighborhood disadvantage on tumor biology and breast cancer survival. Objective. The aim of this study was to evaluate the association between neighborhood disadvantage and Oncotype DX score, a surrogate for tumor biology, among a national cohort. Background. Women living in disadvantaged neighborhoods have shorter breast cancer (BC) survival, even after accounting for individual level, tumor, and treatment characteristics. This suggests unaccounted social and biological mechanisms by which neighborhood disadvantage may impact BC survival. Methods. This cross-sectional study included stage 1 and 2, ER+/HER2- BC patients with Oncotype DX score data from the National Cancer Database, NCDB, from 2004 to 2019. Multivariate regression models tested the association of neighborhood-level income on Oncotype DX score controlling for age, race/ethnicity, insurance, clinical stage, and education. Cox regression assessed overall survival. Results. Of the 294,283 total BC patients selected, the majority were non-Hispanic white, N equals 237,197, 80.6%, with 7.6% non-Hispanic black, N equals 22,495, and 4.5% other, N equals 13,383. 27.1%, N equals 797,254, of the population lived in the disadvantaged neighborhoods with an annual neighborhood level income of less than $48,000, while 59.62%, N equals 175,305, lived in advantaged neighborhoods with a neighborhood level income of greater than $48,000. On multivariable analysis controlling for age, race/ethnicity, insurance status, neighborhood level education, and pathologic stage, patients in disadvantaged neighborhoods had greater odds of high risk versus low risk Oncotype DX scores compared with those in advantaged neighborhoods. Odds ratio equals 1.04, 1.01 to 1.07, p equals 0.0067. Conclusion and relevance. This study takes a translational epidemiologic approach to identify that women living in the most disadvantaged neighborhoods have more aggressive tumor biology, as determined by the Oncotype DX score. Detecting variation in clinical practice patterns for geriatric trauma care using social network analysis. Objective. To characterize hospital-level professional networks of physicians caring for older trauma patients as a function of trauma patient age distribution. Background. The causal factors associated with between hospital variation in geriatric trauma outcomes are poorly understood. Variation in physician practice patterns reflected by differences in professional networks might contribute to hospital-level differences in outcomes for older trauma patients. Methods. This is a population-based, cross-sectional study of injured older adults, age 65 or above, and their physicians from January 1, 2014, to December 31, 2015, using healthcare cost and utilization project inpatient data and Medicare claims from 158 hospitals in Florida. We use social network analyses to characterize the hospitals in terms of network density, cohesion, small worldness, and heterogeneity, then use bivariate statistics to assess the relationship between network characteristics and hospital-level proportion of trauma patients who were age 65 or above. Results. We identified 107,713 older trauma patients and 169,282 patient-physician dyads. The hospital-level proportion of trauma patients who were aged 65 or above ranged from 21.5% to 89.1%. Network density, cohesion, and small worldness in physician networks were positively correlated with hospital geriatric trauma proportions, R equals 0.29, p less than 0.001, R equals 0.16, p equals 0.048, and R equals 0.19, p less than 0.001, respectively. Network heterogeneity was negatively correlated with geriatric trauma proportion, R equals 0.40, p less than 0.001. Conclusions. Characteristics of professional networks among physicians caring for injured older adults are associated with the hospital-level proportion of trauma patients who are older, indicating differences in practice patterns at hospitals with older trauma populations. Associations between interspecialty collaboration and patient outcomes should be explored as an opportunity to improve the treatment of injured older adults. Next article is from Journal of American Medical Association Surgery. Cost-effectiveness of laparoscopic versus open gastrectomy for gastric cancer and economic evaluation alongside a randomized clinical trial. Importance: laparoscopic gastrectomy is rapidly being adopted worldwide as an alternative to open gastrectomy to treat gastric cancer. However, laparoscopic gastrectomy might be more expensive as a result of longer operating times and more expensive surgical materials. To date, the cost-effectiveness of both procedures has not been prospectively evaluated in a randomized clinical trial. Objective: to evaluate the cost-effectiveness of laparoscopic compared with open gastrectomy. Design, setting, and participants in this multi-center randomized clinical trial of patients undergoing total or distal gastrectomy in 10 Dutch tertiary referral centers. Cost-effectiveness data were collected alongside a multi-center randomized clinical trial on laparoscopic versus open gastrectomy for resectable gastric adenocarcinoma, CT14 and 03BM0. A modified societal perspective and 1-year time horizon were used. Costs were calculated on the individual patient level by using hospital registry data and medical consumption and productivity loss questionnaires. The unit costs of laparoscopic and open gastrectomy were calculated bottom-up. Quality-adjusted life years, QALYs, were calculated with a Eurocall 5-dimension questionnaire, in which a value of 0 indicates death and 1 indicates perfect health. Interventions: laparoscopic versus open gastrectomy. Main outcomes and measures evaluations in this cost-effectiveness analysis included total costs and QALYs. Results: between 2015 and 2018, 227 patients were included. Mean SD, age was 67.5, 11.7 years, and 140 were male, 61.7%. Unit costs for initial surgery were calculated to be €8,124, US $8,087, for laparoscopic total gastrectomy, €7,353, US $7,320, for laparoscopic distal gastrectomy, €6,584, US $6,554, for open total gastrectomy, and €5,893, US $5,866, for open distal gastrectomy. Mean total costs after 1-year follow-up were €26,084, US $25,965, in the laparoscopic group and €25,332, US $25,216, in the open group. Difference: €752, US $749, 3.0%. Mean SD, QALY contributions during 1 year were 0.665, 0.298, in the laparoscopic group and 0.686, 0.288, in the open group. Difference: minus 0.021. Bootstrapping showed that these differences between treatment groups were relatively small compared with the uncertainty of the analysis. Conclusions and relevance: although the laparoscopic gastrectomy itself was more expensive, after 1-year follow-up, results suggest that differences in both total costs and effectiveness were limited between laparoscopic and open gastrectomy. These results support centers choosing, based on their own preference, Whether to implement laparoscopic gastrectomy as an alternative to open gastrectomy. Next article is from British Journal of Surgery. Laparoscopic ventral hernia repair, early follow-up of a randomized controlled study of primary fascial closure before mesh placement. Background: suturing of the hernia aperture in laparoscopic ventral hernia repair has increased during the past decade. The primary aim of this is to restore the anatomy of the abdominal wall. Closure of the aperture, however, may cause additional tension in the abdominal wall, which could increase postoperative pain. The aim of this study was to investigate whether suturing of the hernia aperture affects postoperative pain and hernia site complications, including seroma, infection, pseudohernia, and mesh migration, 3 months after repair. Methods: some 192 patients with a midline hernia between 2 and 8 cm in transverse diameter were included in a randomized controlled double-blinded multicenter study. Patients were randomized to mesh repair with intervention or without control suturing of the hernia aperture before mesh placement. Patients completed the ventral hernia pain questionnaire before and 3 months after surgery. Abdominal wall pain and hernia site complications were assessed 3 months after surgery. Results: 97 patients were randomized to the intervention group and 95 to the control group. Among all patients, median age and BMI was 56 years and 31 kg/m2 respectively. Overall pain experience decreased by 3 months after operation, p less than 0.001. There was no difference between groups regarding hernia site complications or pain experienced during the past week, 13 versus 23 patients, p equals 0.111. Seroma and pseudohernia occurred in 13 and 11 patients in the intervention and control groups respectively, p equals 0.975 and p equals 0.977. Conclusion: restoration of the abdominal wall anatomy by suturing the hernia aperture before mesh placement does not increase the risk of hernia site complication or pain 3 months after surgery. This implies that fascial suturing of the aperture can be justified if there are potential long-term benefits such as lower recurrence and/or complication rates. Next article is from Journal of Vascular Surgery. Decreasing prevalence of centers meeting the Society for Vascular Surgery abdominal aortic aneurysm guidelines in the United States. Objective: based on data supporting a volume-outcome relationship in elective aortic aneurysm repair, the Society of Vascular Surgery (SVS) guidelines recommend that endovascular aortic repair (EVAR) be localized to centers that perform greater than or equal to 10 operations annually and have a perioperative mortality and conversion to open rate of less than or equal to 2%, and that open aortic repair (OAR) be localized to centers that perform greater than or equal to 10 open aortic operations annually and have a perioperative mortality less than or equal to 5%. However, the number and distribution of centers meeting the SVS criteria remains unclear. This study aimed to estimate the temporal trends and geographic distribution of centers meeting the SVS aortic guidelines, CMAG, in the United States. Methods: the SVS Vascular Quality Initiative was queried for all aortic bypasses and EVAR from 2011 to 2019. Annual and EVAR volume, 30-day elective operative mortality for or EVAR and EVAR conversion to open rate for all centers were calculated. The SVS guidelines for and EVAR, individually and combined, were applied to each institution, leading to a CMAG designation. The proportion of CMAGs by region, West, Midwest, South, and Northeast, were compared by year using a Chi-2 test. Temporal trends were estimated using a multivariable logistic regression for CMAG, adjusting by region. Results: overall, 67,865 patients, 49,264 EVAR, 11,010 or 7,591 aortic bypasses, at 336 institutions were examined. The proportion of EVAR CMAGs increased nationally by 1.7% annually from 51.6%, N equals 33/64, in 2011 to 67.1%, N equals 190/283, in 2019, beta equals 0.05, 95% confidence interval, C 0.01 to 0.09, P equals 0.02. The proportion of EVAR-CMAGs across regions ranged from 27.3% to 66.7% in 2011 to 63.9% to 72.9% in 2019. In contrast, the proportion of ORC-MAGs has decreased nationally by 1.8% annually from 32.8%, N equals 21/64, in 2011 to 16.3%, N equals 46,283, in 2019, beta equals -0.14, 95% C, -0.19 to -0.10, P less than 0.01. Combined EVAR and ORC-MAGs were even less frequent and decreased by 1.5% annually from 26.6%, N equals 17/64, in 2011 to 13.1%, N equals 37,283, in 2019, beta equals -0.12, 95% C, -0.17 to -0.07, P less than 0.01. In 2019, there was no significant difference in regional variation of the proportion of combined EVAR and ORC-MAGs, P equals 0.82. Conclusions. Although an increasing proportion of institutions nationally meet the SVS guidelines for EVAR, a smaller proportion meet them for OR, with a concerning downward trend. These data question whether we can safely offer OR at most institutions, have important implications about sufficient OR exposure for trainees, and support regionalization of OR. Outcomes following carotid revascularization for stroke stratified by modified Rankin scale and time of intervention. Objectives. The relationship between baseline modified Rankin scale, misses, in patients with prior stroke and optimal timing of carotid revascularization is unclear. Therefore, we evaluated the timing of transfemoral carotid artery stenting, TCAS, transcarotid artery revascularization, TCAR, and carotid endarterectomy, CEA, after prior stroke, stratified by preoperative misses. Methods. We identified patients with recent stroke who underwent TCAS, CAR, or CEA between 2012 and 2021. Patients were stratified by preoperative misses, 0 to 1, 2, 3 to 4, or 5, and days from symptom onset to intervention, time to intervention, less than or equal to 2 days, 3 to 14 days, 15 to 90 days, and 91 to 180 days. First, we performed univariate analyses comparing in-hospital outcomes between separate misses or time to intervention cohorts for all carotid intervention methods. Afterward, multivariable logistic regression was used to adjust for demographics and comorbidities across groups, and outcomes between the various intervention methods were compared. Primary outcome was the in-hospital stroke/death rate. Results. We identified 4,260 patients who underwent TCAS, 3,130 patients who underwent CAR, and 20,012 patients who underwent CEA. Patients were most likely to have minimal disability, misses 0 to 1, 61%, and least likely to have severe disability, misses 5, 1.5%. Patients most often underwent revascularization in 3 to 14 days, 45%. Across all intervention methods, increasing preoperative misses was associated with higher procedural in-hospital stroke/death, all P less than 0.03, whereas increasing time to intervention was associated with lower stroke/death rates, all P less than 0.01. After adjustment for demographics and comorbidities, undergoing TCAS was associated with higher stroke/death compared with undergoing CEA, adjusted odds ratio, 1.6. 95% confidence interval, 1.3 to 1.9, P less than 0.01, or undergoing CAR, adjusted odds ratio, 1.3, 95% confidence interval, 1.0 to 1.8, P equals 0.03. Conclusions. In patients with preoperative stroke, optimal timing for carotid revascularization varies with stroke severity. Increasing preoperative misses was associated with higher procedural in-hospital stroke/death rates, whereas increasing time to intervention was associated with lower stroke/death rates. Overall, patients undergoing CEA were associated with lower in-hospital stroke/deaths. To determine benefit for delayed intervention, These results should be weighed against the risk of recurrent stroke during the interval before intervention. Outcomes of covered versus bare metal stents for the treatment of aortoiliac occlusive disease. Objective. We retrospectively compared the clinical outcomes of self-expanding covered stents, CSs, and bare metal stents, BMSs, in the treatment of aortoiliac occlusive disease, AIOD, at a single center between 2016 and 2022. Results. A total of 209 patients with AIOD were enrolled in the study, including 135 patients, 64.6%, in the CS group and 74 patients, 35.4%, in the BMS group. Surgical success rates, 100% versus 100%, p equals 1.00, early, less than 30-day, mortality rates, 0% versus 0%, p equals 1.00, cumulative surgical complication rate, 12.0% versus 8.0%, p equals 0.891, 5-year primary patency rate, 83.4% versus 86.9%, p equals 0.330, secondary patency rate, 96% versus 100%, p equals 0.570, and limb salvage rate, 100% versus 100%, p equals 1.00, did not exhibit significant differences between the two groups. Patients in the CS group had a lower preoperative ankle brachial index, 0.48 plus or minus 0.26 versus 0.52 plus or minus 0.19, p equals 0.032, more cases of complex AIOD, especially task D 47.4% versus 9.5%, p less than 0.001, more chronic total occlusive lesions, 77.0% versus 31.1%, p less than 0.001, and more severe calcification, 20.7% versus 14.9%, p less than 0.036. After propensity score matching, 50 patients, 25 with CS and 25 with BMS, were selected. The results showed that only severe calcification, 32.0% versus 8.0%, p equals 0.034, and ankle brachial index increase, 0.45 plus or minus 0.15 versus 0.41 plus or minus 0.22, p equals 0.038, were significantly different between the groups. In terms of surgical factors, patients in the CS group had more use of bilateral femoral or combined brachial artery percutaneous access, 60.0% versus 12.0%, p less than 0.001, more number of stents used, 2.3 plus or minus 1.2 versus 1.3 plus or minus 0.7, p less than 0.001, longer mean stent length, 9.3 plus or minus 3.3 versus 5.8 plus or minus 2.6 centimeters, p less than 0.001, and more catheter-directed thrombolysis treatment, 32.0% versus 4.0%, p equals 0.009. Multivariate Cox survival analysis showed that severe calcification, hazard ratio, 1.32, 95% confidence interval, 1.04 to 1.85, p equals 0.048, was the only independent predictor of the primary patency rate. Conclusions. All patients with AIOD who underwent endovascular therapy were included and achieved good outcomes with both CSs and BMSs. The influence of confounding factors in the two groups was minimized by propensity score matching, and the 5-year patency rates were generally similar in the unmatched and matched cohorts. Postoperative hemodynamic improvement was more obvious in patients in the CS group. For more complex lesions, CS is recommended to be preferred. Especially for severe calcification lesions, which is the only independent predictor of primary patency, CS showed obvious advantages. Further studies with more samples are needed to investigate the role of stent types in AIOD treatment. Next article is from Surgical Endoscopy. Active gas aspiration and reducing pain after laparoscopic cholecystectomy, a systematic review and meta-analysis of randomized controlled trials. Background. Postoperative pain is a common issue following laparoscopic cholecystectomy. This meta-analysis aimed to determine if active gas aspiration is more effective than passive gas aspiration in reducing postoperative pain and analgesic requirements. Methodology. The study conducted a systematic search of various databases, including Embase, Medline, and Cochrane's Central Register of Controlled Trials, Central, via Ovid. It also searched trial registries and reference lists of included studies, with no date restrictions but limited to English language, up to December 21, 2022. The study included all randomized clinical trials that had documented elective laparoscopic cholecystectomy procedure and reported at least one relevant outcome. Articles that included subdiaphragmatic drain, intraperitoneal normal saline infusion, or pulmonary recruitment maneuver were excluded from the analysis. 2 reviewers independently and in duplicate assessed the eligibility of studies and extracted data. The study reported findings according to the preferred reporting items for systematic review and meta-analysis, PRISMA, guidelines. The risk of bias of the included trials was assessed using the revised Cochrane Risk of Bias Assessment tool. The study used a random effects model to pool data. Results. This meta-analysis included 5 randomized clinical trials with 367 participants and found that active gas aspiration resulted in significantly lower residual gas volume and total analgesia requirements compared to passive gas aspiration. Active gas aspiration also led to significantly lower shoulder pain scores at 24 hours postoperatively. However, no significant differences were observed in hospital stay duration or abdominal pain scores. Conclusion. The study found that active gas aspiration can be effective in reducing postoperative shoulder pain and analgesic requirements after laparoscopic cholecystectomy, which has important implications for patient care and healthcare costs. Importantly, this intervention does not impose any additional time or financial burden. However, further research is needed to evaluate its impact on other laparoscopic procedures. Next article is from Annals of Surgical Oncology. Laparoscopic liver tunnel for tumors at the hepatocaval confluence. Background. Tumors at the hepatocaval confluence can be treated with parenchyma-sparing surgery, also with minimally invasive approach. 1,2 The liver tunnel was described for tumors involving the pericaval portion of SG1 in contact or infiltrating the middle hepatic vein, MHV. 3 A liver tunnel with laparoscopic approach is proposed. Methods. A 48-year-old woman was referred for 3 synchronous colorectal liver metastases in the pericaval portion of SG1 in contact with the inferior vena cava and the MHV, in SG8 ventral and in SG6, after an urgent left laparoscopic hemicolectomy for an obstructing carcinoma. A laparoscopic SG1 resection extended to SG8 ventral were planned after neoadjuvant chemotherapy. Estimated future liver remnant, FLOR, was 75%, 840 milliliters, of healthy liver, figure 1. In case of right hepatectomy extended to SG1, estimated FLOR was 25%, 280 milliliters, of healthy liver. Results. Pneumoperitoneum is established, and 4 operative ports are placed. SG1 is approached from the left, dividing the Glisonian pedicles and short hepatic veins. MHV is approached craniocaudally from the dorsal side. The resection continues on the ventral side, according to our ultrasound liver map technique with a craniocaudal approach to the MHV. 4 SG8 ventral pedicles are divided and the resection completed with aid of indocyanine green negative staining. A SG6 resection is then performed. Operative time was 480 minutes. Blood loss was 100 milliliters. The postoperative course was uneventful, and the patient was discharged on 4th postoperative day. The 2 parenchyma-sparing resections saved an estimated volume of 75%, 840 milliliters, of healthy liver, figure 1. The estimated remnant liver volume after a right hepatectomy extended to SG1 would have been only 25%. Conclusions. Tumors at the hepatocaval confluence involving SG1 can be removed with a liver tunnel, which can be performed with minimally invasive approach. The laparoscopic liver tunnel pushes further the limit of minimally invasive parenchyma-sparing surgery for ill-located tumors with complex vascular relationship. Next article is from Obesity Surgery. Post-bariatric surgery changes in secondary esophageal motility and distensibility parameters. Introduction. Despite the increasing number of bariatric procedures over the recent years, the physiological changes in secondary esophageal motility and distensibility parameters after surgery remain unknown. Methods. This is a retrospective, single-center cohort study comparing esophageal planimetry and gastroesophageal junction (GEJ) distensibility in post-bariatric surgery patients, Roux-en-Y gastric bypass, RYGB, sleeve gastrectomy, SG, and conversion/revisional patients, DH, and native anatomy patients with obesity, NAC. Distensibility refers to the area achieved with a certain amount of pressure, and secondary peristalsis represents the esophageal response to an intended obstruction. Patients with pre-surgical dysmotility symptoms were excluded from the study. Results. From November 2018 to January 2023, 167 patients were evaluated and eligible for this study. RYGB equals 87, SG equals 33, NAC equals 22, DH equals 25. In NAC cohort, 1722, 77%, patients presented normal motility patterns compared to 3587, 40%, RYGB 1233, 36%, SG, and 525, 20%, DH, P less than 0.05 for all comparisons. The most common abnormal motility pattern for all three bariatric cohorts was absent contractions. DH patients generally had the highest mean maximum distensibility index averages, followed by SG, RYGB, and NAC. Conclusion. Bariatric surgery affects esophageal and physiology, and it is associated with higher rates of secondary dysmotility. DH patients have even higher rates of dysmotility. Further studies assessing clinical data and their correlation with manometric and pH metric findings are needed. Next article is from Journal of the American College of Surgeons. Early discharge after uncomplicated elective colectomy and risk of post-discharge complication. Background. This was a retrospective cohort study of adult patients undergoing uncomplicated elective colectomy using the NSCOP database from January 2012 to December 2019. A colectomy is deemed uncomplicated if there are no complications reported during the hospitalization. The objective of this study was to examine the association between discharge timing and post-discharge complications in patients who undergo uncomplicated elective colectomy. Study design. Patients were stratified into an early discharge group if their length of postoperative hospitalization was less than or equal to 3 days for laparoscopic or robotic approaches, or less than or equal to 5 days for the open approach, and otherwise into delayed discharge groups. The association between early discharge and any post-discharge complication was examined using unadjusted logistic regression after propensity score matching between early and delayed discharge groups. Results. Of the 113,940 patients included, 77,979, 15,877, and 20,084 patients underwent uncomplicated laparoscopic, robotic, and open colectomy, respectively. After propensity score matching, the odds of a post-discharge complication were lower for the early discharge group in laparoscopic, odds ratio 0.73, 95% C 0.68 to 0.79, and robotic, odds ratio 0.63, 95% C 0.52 to 0.76, approaches, and not different in the open approach, odds ratio 1.02, 95% C 0.91 to 1.15. There were no clinically meaningful differences in the risk of return to the operating room for all surgical approaches. Conclusions. Early discharge after uncomplicated colectomy appears to be safe and is associated with lower odds of post-discharge complications in minimally invasive approaches. Our findings suggest that surgical teams practice sound clinical judgments on selecting patients who benefit from early discharge. Effect of standardized reminder calls on trauma patient no-show rate. Background. Most patients who sustain a traumatic injury require outpatient follow-up. A common barrier to outpatient post-admission care is patient failure to follow up. One of the most significant factors resulting in failure to follow up is age more than 35 years. Recent work has shown that follow-up telephone calls reduce readmission rates. Our aim was to decrease no-show appointments by 10% in 12 months. Study design. The electronic medical records at our Level 1 and 2 trauma centers were queried for all outpatient appointments for trauma between July 1, 2020, and June 9, 2021, and whether the patient attended their follow-up appointment. Patients with visits scheduled after August 1, 2021, received 24 and 48-hour pre-visit reminder calls. Patients with visits scheduled between July 1, 2020, and August 1, 2021, did not receive pre-visit calls. Both groups were compared using multivariable direct logistic regression models. Results. A total of 1,822 follow-up opportunities were included in the study. During the pre-implementation phase, there was a no-show rate of 30.9%, 329 of 1,064 visits. Post-intervention, a 12.2% reduction in overall no-show rate occurred. A statistically significant 11.2% decrease, p less than 0.001, was seen in elderly patients. Multivariate analysis showed standardized calls resulted in significantly decreased odds of failing to keep an appointment. Adjusted odds ratio equals 0.610, p less than 0.001. Conclusions. Reminder calls led to a 12.2% reduction in no-show rate and were an independent predictor of a patient's likelihood of attending their appointment. Other predictors of attendance included insurance status and abdominal injury. Next article is from Journal of Trauma and Acute Care Surgery. Modified Brain Injury Guidelines for Pre-Injury Anticoagulation in Traumatic Brain Injury, an opportunity to reduce healthcare resource utilization. Introduction. The Brain Injury Guidelines, BIG, stratify patients by traumatic brain injury, TBI, severity to provide management recommendations to reduce healthcare resource burden but mandates that patients on anticoagulation, AC, are allocated to the most severe turtle, Big 3. We sought to analyze TBI patients on AC therapy using a modified BIG model to determine if this population can offer further opportunity for safe reductions in healthcare resource utilization. Methods. Patients 55 years or older on AC with traumatic intracranial hemorrhage, ICH, from 2 centers were retrospectively stratified into Big 1 to 3 risk groups using modified BIG criteria excluding AC as a criterion. Intracranial hemorrhage progression, neurosurgical intervention, NSI, death, and worsened discharge status were compared. Results. A total of 221 patients were included, with 23%, 29%, and 48% classified as Big 1, Big 2, and Big 3, respectively. The Big 3 cohort had a higher rate of AC reversal agents administered, 66%, compared with the Big 1, 40%, and Big 2, 54%, cohorts, p less than 0.01, as well as ICH progression discovered on repeat head computed tomography, 56% versus 38% versus 26%, respectively, p less than 0.001. No patients in the Big 1 and 2 cohorts required NSI. No patients in Big 1 and 3% of patients in Big 2 died secondary to the ICH. In the Big 3 cohort, 16% of patients required NSI and 26% died. Brain Injury Guidelines 3 patients had 15 times the odds of mortality compared with Big 1 patients, p less than 0.01. Conclusion. The AC population had higher rates of ICH progression than the Big literature, but this did not lead to more NSI or mortality in the lower turtles of our modified BIG protocol. If the modified BIG used the original turtle management on our population, then NS consultation may have been reduced by up to 52%. These modified criteria may be a safe opportunity for further healthcare resource and cost savings in the TBI population. Thank you for listening to This Week in Surgery, your filtered medical journal summary. Have a great week ahead, stay blessed and be humane.